is Dr. Vijayshankar from Apollo Hospitals, Chennai. So as Dr. Dressler described about how many muscles are there that we inject, we need to understand the anatomy and identify how these muscles are placed along each of the planes in the neck. So Dr. Vijayshankar will be throwing more light on this by describing about the cervical muscular anatomy and surface marking, the art of the same.
Thank you, Prashant sir, and Gofik for inviting me from Chennai. And Prashant sir is like a mentor for me. Whenever I have trouble, the first person I can call is Dr. Prashant sir. He always guided me correctly, probably. Okay, so I'm going to talk about the cervical muscular anatomy, surface marking, the art. Always, it is very, very difficult to talk after such a legend. And you can see there are some, we both are covering the same because I thought of, okay, let us go in different way. I thought of prepared some slides, but most of the topic was covered by sir. Let's see. So this is one of my patient. You can see the neck is going backwards, and the left shoulder is elevated, and you can see the hands. Both the hands are like a flexed dystonic posturing of the hand. So he has got a, you can see the eye of a tiger. So it's a pecan. So classically, we divide cervical dystonia into 4 types. One is if the head is tilted forward, it is antrocholis. If the head is tilted backwards, it is retrocholis. If the head is tilted to the sides, it is laterocholis. If the head is tilted to the sides, it is torticollis. More than 50% of the time, we have torticollis. With any combination, it can be there. Because many times when you inject, we don't get the good results. So when you look into it, so there are some patients will have more deviation in the upper part of the neck or more in the lower part of the neck. So we subclassified into caput and collis. What is caput? Caput means the muscles which is activated above the C2 level. Collis is the muscle activated below the C2 level up to C7 level. So if in the frontal axis, if the patient is having the turn, that is torticollis, and if it is a transverse, that is an antro or retrocollis, or if it is sagittal, that is laterocollis. So just repeating it, the muscles above C2 is dystonic, that is tortic caput type. If the muscles below the C2 is torticollis subtype. So when you subclassify into still, if the muscle below C2, if it is like more dystonic, that is laterocollis. If it is above, laterocaput. Similarly, if the muscles above C2 level is more, so below C2 is torticollis, torticaput. Similarly, we have antrocollis, antrocaput. If the neck is bent backwards, retrocollis, retrocaput. The important thing is you should recognize 2 important things now. One is lateral shift and another one is the sagittal shift. So it's not simple. When I talk about the first 4 things, life is easy. But when you include more and more, life is more complex. If you look at this gentleman, you can see a little bit of head is deviated to the left, so mild laterocollis. Okay, we can easily inject, but always observe the patient. As our professor has told, ask the patient is to close the eyes. Look at all the 360 degrees. So he also has a retrocollis. And also, because of this compensating, he is always trying to pull the neck forwards. So always look for the compensatory mechanisms. Always look at the turn, whichever the side. Even every single cervical dystonia never have only one single axis. They have multiple axes of involvement always. The important thing is, this cervical dystonia never read the books. It always troubles us. So look at the patient. Many patients will have retrocollis as well as a laterocollis, torticollis, like any combination. So ask the patient to close the eyes. Always examine the patient, like observe, observe, observe. Ask the patient to turn the head to the right, left, look for the null point. If it is a mild cervical dystonia, if you ask the patient to put it to the opposite side, they may have some tremors. So look for the clinical signs. Always when you are examining, ask the patient, look for the any muscle, enlargement is there. So always, if it is cervical dystonia, always ask the patient to remove the shirt, examine. That's very, very important. Never hesitate to examine. So, which muscle to inject? I have shown you 8, 9, 10 different types, more and more. Even, see, so it's very, very difficult always. So important thing is the anatomy is very, very important. So if a patient is having retrocaput, always the primary muscles is semispinalis capitis, upper trapezius, and the suboccipitalis and splenius capitis. If you are injecting the first time, always never select more than 2 or 3 muscles, because it is important. First select 2 or 3 muscles, inject, start with the low dose, and gradually every 3 months increase the dose. Because on the first time, the standard thing which we use it is start the maximum dose and try, the patient will have a side effect. And the initial period, if you have a side effect, if you have a swallowing difficulties, you will get demoralized. The patient will spoil your name. So start slow, tell the first time. I always tell my patients, I'm going to inject you first time. I don't know how you are going to respond. Let us start with low dose. If you are responding well, if you are tolerating, next time I'm going to improve. So otherwise, if you inject on the higher dose, if you have side effects, next time we'll come and create a lot of ruckus in your clinic, you'll be in trouble. So always one bad patient will spoil your name. So go slow. When you are confident, increase the dose. No problem. You know how to inject, how much you inject. That's fine for us. So the important thing is always, when you are injecting first, always target the primary muscle. Second time or third time, if the patient is increase the dose, if the patient is not responding, add the secondary muscles later on. Go step by step. So if you are looking at the semispinalis, it's exactly in the midline. So look at the occipital pedals, 1 centimeter both the sides. That's the semispinalis, as simple as that one. So it originates from the transverse process of the upper thoracic C4 T1 to T6 and inserts from the superior or inferior nuchal lines, just nuchal line. From the nuchal line, go for 2 millimeters down, 2 centimeters down, 1 centimeter sides, that's a semispinalis. It extends and lateral flexion of the neck like this and assists the rotation of the head. So as simple as that, look at the muscle, 3 spots, 1 centimeter lateral to the central, that's it. Trapezius, which is the next muscle I always prefer. It's a origin from the middle third of the superior nuchal line of the occipital bone, from the occipital bone, and slowly it goes under spinous process C7 to T1. It's a large upper trap, middle trap, and lower trap. When you're looking at the cervical dystonia, we always concentrate on the upper trap. So they inserted at the lateral third of the clavicle. It usually elevates the scapula as well as the pulls the neck backwards. But if it is unilaterally involved, it pulls the neck to the same side. So if you look at the muscle like this, as Prof has mentioned, look at the muscle. So if it is more of the pulling in the backwards, we prefer to inject on the upper part. If it is more of a shoulder, always inject the first 2 things, or wherever. If it is a lateral shoulder is elevated, inject these 2. Middle, at the angle, and the lateral part of the trap. If it is more of a pulling on the upper side, inject on the top and the angle of the traps. Next one is splenius. It's like a fan-like muscle, like this. So always it originates from the lower of the nuchal ligament, from the C7 to T4, and insertion in the mastoid process and the superior nuchal line. The action is rotates the head to the same side, ipsilateral rotation, as well as the laterally flex the neck, like it flexes the neck like this. If the patient is having a pull, always target the splenius semispinalis, and the splenius capitis is one of the first few muscles we touch regularly. So same. So the muscle is going like this, so you should inject here. I think Prof has told you everything, so I don't want to go into it again and again. So the next thing, as I discussed earlier, the obliquus capitis inferior is the newest muscles which we start to inject. It's a very small muscle. It originates from the spinous process of C2 and the inserts in the transverse process of the C1. It rotates the neck to the same side like this. So first, start with the longest primary muscles, look for whether it is improving, increase the dose. If it is not improving, go for the smaller muscles later on. So this is the OCI. This video was given by Vikram and Paul sir. See, you can see in the EMG, this is the OCI. So if somebody is using EMG guided, that's the easiest way. Or, sorry. If somebody like me, I'm not using the ultrasound, I always use the EMG. Look at the crease of the almost end of the hairline, easiest thing. Just 2 centimeters away from the midline, and then you can inject, and always ask the patient to turn the head to the right. If you turn the head, look at the EMG sound, that's the OCI. Retrocolis, similarly, the muscles are almost similar. Splenius capitis, descending trap, semispinalis capitis, and suboccipitals. Then comes the antrocolis. You can see the neck is bending forward. This is what we are discussing. Like patients with MSA always have the antrocolis. And always one of the, even retrocolis also we can easily treat, but antrocolis is always difficult. They may not respond well to our Botox. Always be careful, because when the patient is not improving, they will come and ask you, sir, what to do, what to do. We'll tend to increase the dose and we'll have swallowing difficulties. That's always, so otherwise this is the caput. You can see it is like this, caput. So the commonest muscles injected are bilateral sternocleidomastoid, levator scapulae, bilateral scalenus medius, and longus colli. The sternocleidomastoid, it has 2 heads. One is the sternal head and the clavicular head, and it starts from the sternum and the clavicle and inserts in the nuchal line of the occipital lobe. It pulls the head down, and also unilaterally it tilts the head towards the same side. So we inject the sternocleidomastoid on the, as professor has mentioned, many people use it, just hold up and ask the patient to hold the hand and pull the neck towards the side. Look at the SEM, hold it tight. If you are you are good in EMG, just you can directly inject directly like this. When you are starting, don't inject directly, because carotids are behind. You will always worried whether you are injecting into the carotids. Use EMG. If you are not using the EMG, go from behind, inject from the behind like this. So if you inject from the behind, you will not touch the carotids. Always inject in the upper part of the SEM. If you go below, there is a high chance of patient is having the swallowing difficulties. Inject in the upper part. Always start with 20 units. If you require more, always inject in 2 different doses, like 20 plus 10 or 15, something like that. Don't inject 25 or 30 in this one single shot, because if you give it in a one single shot, there is a chances. There are many studies have shown that if you divide the doses, like if you inject in multiple spaces, the chances of improvement is more. So always inject in 2 different doses. And the other thing is, the standard thing, if somebody is having a torticollis, the standard thing which many centers follow is open 100 units of Botox, like 70-30 or 60-40, something like that. That's a routine standard dose we use. But if you're injecting first time, always inject 20 to 25 in the SEM. Don't inject more in the SEM, because if you have swallowing, many times we may think that the SEM is like a toad. Sometimes we may feel that, oh, it's obviously nothing else. But that is maybe a secondary cause. Sometimes levator can be the cause. So we may get like a caught in these patients. So always put a EMG needle if you have doubt. If the patient is having, even the both the same, many times if patient will have sometimes like this, one side of the muscles are very active, another side may not be active. Put an EMG, you know that which is more active. If it is active, inject more. As I told you earlier, the easiest way is SEM in the upper part. Scalenus, just look at the SEM. Anterior 1/3 is scalenus, middle 1/3 is levator, the upper 1/3 is the splenius capitis. So easiest way to inject. The scalenes we don't use very frequently. When the patient is not responding, we'll go for the scalenes. Its origin from the posterior tubercles of the C2 to C7 vertebrae, and the insertion in the posterior groove of the first rib under the subclavian artery. It always flex the neck to the lateral part. Always, as Professor mentioned, ask the patient to pull the neck, look for the scalenes, hold the scalenes, always hold the scalenes, and then you can inject. Use a EMG. Always for scalenes, better to use a EMG, that's very safe. Like this, you can inject. Sometimes longus colli, if the patient is not responding, many people use longus colli. You can see the video. So just hold the trachea and then just pull it out, and you can inject like this. Always use a EMG for these patients. So antracaput, similarly bilateral SEM. Usually, many books says that the SCM are the secondary muscles, but we prefer to inject SCM as the primary muscle. Longus capitis, levator scapulae, and longus colli as the last resort you can use it. So for the longus capitis, it is originates from the anterior tubercles of C3 to C6 and inferior surface of the occipital bone, and it flexes the neck and head and neck, lateral flexion of the neck, and stabilization of the cervical spine. Longus colli, it originates from the superior, it has three parts, like a superior vertical and inferior oblique part. It originates from the anterior tubercles of the C3 to T3 and inserts in the C1 to C6. Same, it also flexes the neck with a lateral flexion and also rotates the neck. This is a longus colli. You can see with the ultrasound guided. Yeah. Always when you are injecting with the ultrasound, always wiggle the muscle. You know where you are. If see they are wiggling that, you can see the muscles are moving. You know that you are in the longus capitis muscle. The other way around is inserting through the nose. Some people, it's very, very complex, but some people prefer to use it like this. So once again, they are going in. Okay, and the next one is a lateral collis. So for the lateral collis, usually the ipsilateral sternocleidomastoid, ipsilateral levator scapulae, if required ipsilateral semispinal, whether the always look for lateral collis, whether it is more tilted towards the anterior or tilted to the posterior. Depending upon, you can select the muscles or scalene medius. Similarly, you can see this gentleman neck is going to the, he is having the similarly the left lateral collis as well as the chin is going to the right side. So, and he also is having compensate. He is trying to talk with the pulling of the muscles. So always never inject a compensatory muscle. That's a dictum. Assess the patient. If always inject the primary muscles, look for the compensatory muscle. If the compensatory muscle, don't inject it. Just leave it. So for torticollis, contralateral SCM and ipsilateral splenius capitis is the important muscles. Torticaput, contralateral SCM, contralateral trapezius, and ipsilateral OCI. Shoulder elevation, we often see this one. If the neck is more towards like this, you can inject the medial levator scapulae. If it is lateral shoulder elevation, you can inject the transverse trapezius. So we often see this one. Now it is very, very, Pushpa 2 is very, very famous. So we need to inject this guy. Whoever injects, they will get a lot of money. Millions will earn. Probably we can take a photo, so if we put, we will become the national hot sensation. Okay, the next complex thing is the backwards sagittal, the double chin, which I showed you. Retrocollis as well as anterocapul. For this, we need to inject the suprahiatal muscles, digastric. Just digastric is very simple. Just midline, one finger below, backwards, and one finger lateral. That's all, two sides. You can inject like this. Or longus colli, simplest thing is digastric as well as SCM. That's the easiest muscle we can inject. The other complex is forward sagittal shift, anterocollis with retrocaput. So these patients, bilateral SCM, for the retrocaput, we can go for bilateral splenius capitis and suboccipitalis. These are the muscles we can inject. Another complex is lateral shift, lateral collis plus contralateral lateral caput. For this more complex, you can inject ipsilateral SCM, ipsilateral splenius capitis, ipsilateral levator scapulae, descending trap, contralateral SCM, descending trap, contralateral splenius capitis, semispinalis, longissimus capitis. The important thing is, first inject the patient on two muscles. Ask him to come after a month or ask him to take a video a couple of times, reassess. You know what all the muscles are improving, which are the muscles you need to inject, which is more taut, reassess, increase it, add on the next muscle. Slowly add one or two muscles, then you will end up on the right dose. So when the bond failure occurs, one, incorrect identification of the dystonia, whether it's a shift or collis, all these things. One, the important thing is we are scared to increase the dose, patient is more fragile, so suboptimally we always inject. Always because of the compensatory muscle, sometimes we may end up in injecting the wrong muscle. sometimes, as I told it, when they are looking at it, they will try to turn the head towards talking to you. So sometimes the compensating muscles, we are injecting the opposite side also. And as I told you, inadequate dosing, every time, look at the patient, assess. First, initially, we will be having the torticollis. Sometimes, when you are injecting later on, the patient can have some developed retrocollis. So, the pattern of dystonia is changing. So, every time, reassess the patient and select the muscles every time, assess, reassess. That's very, very important. As I told you, avoid the compensating muscles. The take-home message is, assess the patient carefully. Don't inject immediately. I always ask the patient to come today, take a video, go home, reassess the muscle, what are all the muscles, read the muscle. Don't, if the patient says, sir, I have muscle, bus, I have to cap, flight, all these things they will say. When you are injecting, take a video, go home, read the book, select the dose, talk to your friend, whatever, phone a friend, like all the options you can use it. Come back and inject. That is the safest way. After like a 20 injection or 50 injection, you know what are all muscles to inject. So you can you can plan it out. The first few injections, take your time. Select 2 or 3 muscles initially. Mainly, as I told you, inject the primary muscles. Don't inject the secondary muscles. Slowly, you can, when it's not assessed after 1 month, include the other muscles and increase the dose. As I told you, start with low dose, gradually increase, and assess the dystonia change in pattern every visit and select the muscles. And if there is a complication, don't say that, oh, this can be other reason, this is a reason. Tell them that, yeah, I told you earlier itself, it can have a side effect. The important thing is, it's a good news. You had a side effect. I usually use 300 units, 400 units for this type of patients. You got it within 150 units. So it means next time I can use it less unit and you can save the money. Patient will be really happy. Oh, really? Huh? You are a very nice person. You are brittle. And that's the reason. But with low dose itself, I can cure you. Then patient will say, ah, yeah, cha, doctor, hey, sir. So, yes, sir. Yeah. So the important thing is, as I was told, find the ceiling. Then always mark it in red. This is a level you should not go beyond. So always keep it every The important thing always, every time document and the doses and keep it safe. Because if you don't keep it safe, next time you don't know how much you are injected, how much is the complication. Always look at your old notes and then increase, like whenever you're increasing, increase 20 to 30%. Don't go beyond the 20 to 30%. Go slow. That's very, very important. Thank you. So the important thing is, many times, if the patient is having a cervical dystonia, like our Pushpa, so if you have a cervical dystonia, shoulder rotation is there, the arm always goes like this. If you look at the Pushpa, he will be clearly doing like this. So I have seen many patients, whenever they are having a cervical dystonia, they will always have the hands like, many people are injected the shoulders, they are injected the arms, biceps, everything they are injected. So that's, they will say, patient is not improving, because we are using, patient cannot buy more than 200 to 300 units. So you will be using at least 100 units here, only 200 units here. So only half of the dose you are injecting. So the patient will not have benefit. So as I told you earlier, look at which is the primary muscle, inject there. Anything else you want to add, sir?
Can I tell you?
Yes, sir. Please give us.
Once I had a patient and who comes like this. And so he has a flexion dystonia. Correct? So I always teach my students that whenever you want to assess cervical, ask him to stand erect, look forward and walk. So walk in a neutral position. Now you look for the dystonia. So when he did that, he had severe retrocollis. So he was compensated in his neck movement. So if you don't do what I said, you ask him to walk in a neutral position, you will miss the point. That's what he's telling. So if you want to neutralize what is the compensative phenomena, ask him to keep the neck straight and walk. And also I do talk. When you are walking, you talk. So that sometimes precipitates. Some people have while eating. So I make them sit and ask them to eat. So ask them to drink water, eat food, talk, and then you can see the actual dystonia. You can differentiate it from what are other compensative movements. You want to make some comments?
No, it's exactly what I try to describe with the term we are using, preventive postures. They do the opposite, not in order to get in the neutral position when the retrocollis in that case would kick in. So preventive posture, they do the opposite, because when they get close to the dystonic position, then it's unpleasant. They pull it back. Yeah.
Yeah, I have burnt my fingers when you are first injecting first few times when after neurology. We will always think, let's do like this. Patient was like this. I thought, okay, he's having a anthracolis. I injected bilateral SCM. Suddenly they came, sir, my dad is having weakness. Hmm? Okay, come him. His neck was like this. I thought I was injected too much here. And then I realized I spoke to my friend. I injected 20, 25, something like that bilaterally. Should I inject only one side? That's what the discussion we had. Sarah asked, should we inject? I had the same doubt. Whether I should inject only one side first or initially to both sides. I have injected too much, 25, 25, because it's an initial period. I don't know. Then I showed it to my friend. He told that let him come back after 3 months. Then we asked him to walk. I didn't ask him to walk. That's the important thing. When he asked, he was walking like this. To compensate, he was bending the neck. So always look at that. That's very, very important.
I tell my residents I have done all the complications. When somebody says I have not done complications, I say you haven't injected enough.
Yes. So never worry about the complication. Yeah? Complication is a way of learning. Next time you will not do the same mistake again. It will be like a red flag, always in your mind. I have done this one. So we need to be careful. So don't worry about the complication. Botox is making complication and learning. That's important. And try to teach your friend. Don't do this one. I have done this mistake.
What you did last time.
The other thing is, I had a patient who severe cervical dystonia like this. I have done a DBS. Patient was not at all happy, not at all happy. I was using EMG. Whenever I put the EMG, it was like a sound, not everything. I had not at all injected. I have not at all activated. When I put it, very, very sound was that. I thought, okay, the needle was not working. I throwed it. Okay, I throwed it 3 times. Then when I realized the same needle, I thought, okay, why it is happening like this for 3 times? Then I realized it was DBS is producing interference. Look for this interference always. It's from learning from our mistakes. I had not at all activated. I thought bilateral severe dystonia. No,
and if you're injecting somebody with a previous DBS, be very, very careful that you're not hitting the cables.
Yes, sir.
Because I have seen patients who lost their devices because somebody had injected into the cable. They got infected or they got hit directly. Try to avoid this.
I inject only one side. I never inject the other side. I leave it.
I hold the wire.
Yeah.
Yes.